physician for follow-up routine. He has type 2 diabetes treated with and peripheral vascular disease. Current medications, metformin and glyburide, uh, dorsalis pedis, and posterior tibial pulses are decreased bilaterally. Serum lipid studies show cholesterol 1 year ago was 190, today is 180. Let me see. So it's fine. HDL was a year ago was 39. Today is 37. Small, getting lower. LDL 1 year ago was 139. Today is 135. So it's fine. And tax 1 year ago was 180. Today is 140. So that lower is good. Which of the following is the most appropriate recommendation?
Why is that?
I mean, everything is good, right? Everything is getting.
No, not everything is good. Like according to the, if you think about the statin therapy, there was a box, primary prevention and secondary prevention. In
Mhm.
primary prevention, there is LDL more than 190, one criteria, age more than 40 with diabetes. So age more than 40 and she has diabetes. And sorry, he has diabetes. So age more than
Mhm.
40 with diabetes. So we can give statin. I am thinking like it may
Mhm.
be. And another criteria was ASCVD scoring, atherosclerotic cardiovascular risk. If it is more than 7.5 to 10, then give statin, isn't it? The primary prevention
Mhm.
one, the box. And secondary
Mhm.
prevention is like the stroke, TIA, and history of acute coronary syndrome. There may be other causes too. I don't remember. So on
You
that,
can give.
lipid lowering therapy should be given. But they told that to decrease LDL cholesterol less than 100.
That's why I was like, it cannot. Okay, if
Okay,
you okay, you can pick it. Okay, let's see.
okay, let's see.
20. Ah, with the right one. I'm so behind. 24.
So it is right, isn't it?
Sorry, I'm still trying to get to the thing. 23 and 24. Yes, it's D, lipid lowering therapy to decrease the cholesterol to less than 100.
No? Yes.
Mm-hmm.
Okay.
You're right.
So it is that box. So I think that some of them is like remembering, like some of the box we should remember. Okay. These patients lab studies These patients' lab studies show an increased serum LDL cholesterol concentration. Risk factor for hypercholesterolemia include family therapy, physical inactivity, obesity, diabetes, CKD, and nephrotic syndrome, thyroid dysfunction, tobacco use. Hypercholesterolemia is associated with hypertension, cardiovascular disease, and cardiovascular disease and complications of the diabetes mellitus. Patients are typically asymptomatic and the diagnosis made by routine screening panel. In addition to evaluating for secondary cause of hypercholesterolemia like checking thyroid function and HbA1c, a chemistry panel and urine analysis to assess the kidney function. The patient should be counseled on dietary modification, weight loss, and increased physical activity. Lipid lowering therapy to decrease LDL cholesterol concentration to less than 100 milligram per dl should be recommended, and the patient is likely to benefit from statin therapy given the presence of diabetes mellitus and significant clinically significant cardiovascular disease with evidence of mm, with evidence of diminished distal pulses on examination. Okay.
Okay. Oh, sorry. Um, 25. 77 women resident of a skilled nursing care facility brought to the physician because of 1 week history of heartburn and difficulty swallowing. She has had no weight or she sustained a cerebral infarct 2 years ago. She has hypertension, hyperlipidemia, medication, ortalidone, potassium chloride, alendronate, aspirin, lovastatin. Exam shows no abnormality except for residual right-sided weakness. Upper endoscopy shows two shallow ulcers in the distal esophagus. What's the diagnosis?
Shallow also. Is this also due to friction? Like chlorthalidone is a big, like thiazide and potassium alendronate. These are the big drugs. This can cause drug-induced esophagitis. Is this drug can cause ulcer?
I think it's the drug induced. I don't know if it can cause esophagitis, but it's the only thing that may. It's not cancer because she's not losing no weight.
Yes.
Um, reflux esophagitis. Doesn't, I don't know, maybe
Reflux
herpes.
esophagitis, like if GRD type of feature. He has only 1 week history of heartburn.
Yeah, and then reflux. I don't think she has any.
I think,
Thing.
and
The
Barrett,
herpes.
yes.
The
Sorry.
herpes ulcers are they are shallow. It's true, they're shallow, but she doesn't have any risk factors for herpes.
By like herpes.
Yeah, they have. I think they
The-
have shallow
If there
ulcers.
is like HIV, then herpes would be the answer. But the patient is
Yeah,
not immunocompromised. Okay.
yeah. Let's see. Where are the answers? Okay.
Okay.
Yeah.
Okay. It is drug-induced esophagitis. The drug-induced esophagitis can result from a variety of medication, including aspirin, bisphosphonate, alendronate, tetracycline antibiotic. It it is thought it is thought to be primarily a result of direct irritation of the esophageal mucosa. Drug-induced esophagitis is more common in elderly patients because of a variety of factors, including polypharmacy, increased GI transit time, decreased salivary production. Endoscopy may reveal localized ulceration. Treatment discontinuation of the offending medication. Most patients experience a rapid improvement in symptoms after the offending medication is stopped. Okay.
Can you read ADE?
Yes. Barrett esophagitis is a state of Premalig Barrett esophagitis is a state of premalignancy marked by intestinal metaplasia of the distal esophagus. Patients typically report long-standing history of heartburn and may experience odynophagia. If untreated, Barrett esophagus may progress to esophageal cancer. Barrett esophagus may progress to esophageal cancer, adenocarcinoma, which presents with progressive dysphagia, odynophagia, and weight loss. Herpes simplex esophagitis typically occurs in patients with history of immunosuppression, such as patients with the HIV, such as patients with HIV, patients undergoing chemotherapy, or those who have undergone organ transplantation. Reflux esophagitis presents with chronic heartburn that is worsened after meal while lying down. Patients often report history of heartburn. They may also develop associated cough, sinus pain, halitosis, prolonged reflux esophagitis, increase the risk of bad esophagus. Okay.
Okay. Next, previously held the 8-year-old boy comes to physician 1 week history of itchy, non-painful rash on his arm. Mother said that it began small red spot but has tripled in size since then. He has had no other symptom. Oh, what the hell? Oh, photograph of the rash is shown. Which of the following is the treatment? That's the fungus, right?
Hmm.
The how you call them?
Ringworm,
No, those ones.
like tinea.
Tinea or no? Is
Yeah,
it?
looks like.
Okay. Ready?
So if it is tinea, then clotrimazole would be the answer. It is like tinea cruris. Uh,
Um, mm,
no, tinea
no.
corporis.
Okay. Uh-huh.
Corporis.
Okay.
Mountain
Let's see.
infection.
Yeah. Okay.
Okay. Tinea corporis is a common superficial cutaneous fungal infection caused by dermatophytes. Most This disease is very, very common in our country. This
Oh,
kind of
really?
disease, yes, but it is very hard to treat
Mm.
as because people are taking steroid and lots of drug which are not
Mhm.
necessary for this tinea
Mm.
infection. Okay. Uh, Tinea corporis is common superficial cutaneous fungal infection caused by dermatophytes, most commonly Trichophyton rubrum. By definition, tinea corporis involves the body or extremity, while dermatophyte infections of the groin, tinea cruris, foot, tinea pedis, scalp, tinea capitis, nail, tinea anguyam, are separately named. The most common presentation of the most common presentation of tinea corporis is round annular patches with scaly borders. Potassium iodide preparation Potassium iodide preparation will show hyphae. A fungal culture may be performed to confirm the diagnosis and species determine the causative species before initial empiric treatment. First line treatment tinea corporis is a topical antifungal using cotrimazole, terbinafine, ketoconazole combined. Topical antifungal and corticosteroid are not advised in the treatment of tinea corporis given the likelihood of worsening the disease with cortical. This line is very important. Like uh, there are some antifungals mixed with the corticosteroid. If you use this, initially the patient gets better, but in the long run, the disease will not gonna heal. Okay.
Okay. So, I
Permethrin
will.
is for scabies. Selenium sulfide is for seborrheic dermatitis, and hydrocortisone. These topical corticosteroid usually not used in the tinea infection. It is used in the atopic dermatitis, like uh, those things. Contact dermatitis. Steroid actually indicated for atopic dermatitis, contact dermatitis, or like lichen disease, like lichen planus. Okay.
For tinea, let
There
me
are
see.
lots of tinea. Tinea cruris, corporis, tinea anguium.
For tinea cruris, do you use oral or do you use topical?
Usually, or not only topical, it does not help in curing. You have to use oral drug also, and it should be taken as far as the if you look at the guideline, it should be given for prolonged period, like 2 to 3 months, because
Okay,
these things actually don't get out from your body easily.
okay.
Very yes.
From what I had read, it says only capitis and the nail one. Wait, and the nail one. That's when you use oral. Everything else you use topical. Yeah. So the
So
yeah,
sorry.
for
Yeah.
the two tinnias that you use oral are only capitis in the and the nail one, the inguinum. Everything else you use topical one.
Okay.
For those one you use oral.
We actually use topical and oral in all aspect. I don't know
No.
it is written anywhere in. Is there anything written in the
Yeah,
first aid?
I have read it somewhere, and then there was a question, and you were
Okay,
um yeah.
then we should be focused on that question. If you found, then just uh, share me.
Yeah, okay. 16 boy brought to physician because of 1 year history of severe acne that has not responded to treatment with over-the-counter topical medication. He has no history of serious illness, no medication. He works in a garage. On weekends, I participate in track team at school. He occasionally drinks coffee in the mornings and soda after work. BMI is fine. Weight five.
What is your diagnosis?
I don't know.
Sorry.
Just acne.
Yes.
In addition to oral antibiotic and topical retinoid therapy, which of the following is the most appropriate recommendation? And they already gave an antibiotic and retinoid. Hmm,
Who works in a garage. Uh, tracked him at this school.
the garage. No, it's not fat. Oh, why is it doing that?
No, on the track team. Um, he works in the garage, so it is not the sun exposure, isn't it?
Um, but he participates in track team.
Yes, that's the thing. Track team, what does it mean?
The people that run,
Oh, okay, okay.
Abidam,
Oh, sorry.
thinking. Ready?
Yes,
Okay.
okay. So it's avoidance of sun exposure. Uh, when starting tetracycline, when starting a tetracycline antibiotic for the
Mm,
treatment of the acne, it is important to counsel the patient to avoid sun exposure, as even small amounts of sun exposure can cause phototoxicity. These patients these patient physical examination shows scattered open comedones, pustules, and inflamed papule consistent with a diagnosis of moderate inflammatory acne. Oral tetracycline, including tetracycline, doxycycline, minocycline, may be used for moderate to severe inflammatory acne. While there is a component of bacterial overgrowth to the pathogenesis of the acne, these antibiotics are used primarily for their anti-inflammatory effect. To prevent bacterial resistance, they may be used at lower doses than would be required when treating an infection, all patients prescribed oral tetracycline should be counseled. All patient all patients prescribed oral tetracycline should be counseled on the possibility of the GI upset, phototoxicity, and peel esophagitis. Minocycline has an additional risk, drug-induced lupus, and a pigmentary change of the skin. So, okay.
32 men comes to physician because of painful blister on his penis for 2 days. During the past 2 years, he has had similar blister that occur approximately 4 times annually in last 10 days. 6 months ago, viral culture of the fluid from a blister was negative. He currently takes no medication, no smoking. He has had 6 lifetime sexual partners and does not use condom. His current sexual partner is asymptomatic. Temperature is a bit high. Pulse is fine. Respiration fine. BP fine. Bilateral inguinal lymphadenopathy. Exam of the penis shows 3 millimeter vesicular lesion on the shaft. Which of the following is the most appropriate pharmacotherapy? And it's painful.
Painful ulcer, isn't it? Painful blister, but
Mhm.
the node is not written. Is the node is painful?
Doesn't say. No, I don't think it's. No.
But 3 centimeter vesicular. Uh, vesicular is the vesicular lesion is aside like herpes.
Kinda. It's the only one that is painful that I remember is painful. It's
Clama,
herpes is painful
clama,
and
chlamydia has
chlam-
painful. Sorry,
chlamydia is. I don't think the lesion is painful. Is the
nodes
lymph
are
node.
painful.
Uh-huh. And then what is ceftriaxone? Ceftriaxone would be
Cef-
like in Nigeria.
Ceftriaxone for gonorrhea.
Does gonorrhea has lesion? No, I don't
No,
think so.
no.
I don't, no. Ready?
And penicillin has painless ulcer and painless node. Okay.
Mhm. Okay.
Okay. Uh, acyclovir is the most appropriate pharmacotherapy for patients' genital infection caused by herpes simplex virus. Herpes simplex virus typically begin with the formation of the vesicle, which lies and progress to shallow and painful ulcer with an erythematous border. Genital herpes is most often caused by HSV2 but can be caused by HSV1. In contrast, herpes labialis is often caused by HSV1 but can be caused by HSV2. Co-infection with both strains are also possible. Genital herpes is transmitted through sexual contact. Following initial infection, it may be latent in the sacral ganglia until reactivation, when it causes painful vesicles and punched out erosions on the genitalia with associated inguinal lymphadenopathy. Viral culture should be taken from the base of a vesicle that has just been deroofed, not the blister fluid, which explains this patient's recent false negative result. Treatment for herpetic infections involve drugs that inhibit viral DNA polymerase, classically by guanosine analogs such as acyclovir, valcyclovir, and famciclovir. Okay.
Okay. Next. Previously healthy 22 woman comes physician because 3 day history of malodorous vaginal discharge. Malodorous. Hmm. She had not had fever, chills, or pain with urination. Menses 28 days interval, last menstrual period 2 weeks ago. She uses OCP and has not missed a dose. Temperature is fine. Pulse fine, respiration fine, BP fine. Abdominal exam, bowel sounds fine. Pelvic exam shows gray, thin, watery vaginal discharge, but no abnormalities. Urine and pregnancy test fine, negative. Oh, you can see the photograph. Results of of the gram stain.
Is
Results
it,
of
isn't
cervical.
it looks like clue cell?
Yeah. Most appropriate next step.
Okay,
Okay.
okay. There is one question like in PAPS, if the patient is asymptomatic, is there any question like if the patient is asymptomatic and the PAP showing the organism, then don't treat? Is there anything, any question you have seen like that?
That okay. Repeat the question. I don't understand.
Like patient is asymptomatic and you
Uh-huh.
subconsciously found this organism on the PAP test. So on
Asymptomatic.
that
Mhm.
on that stem there is the option do not treat, like you need not the treatment.
No, I haven't. Have you seen one?
I, I may mix with another question, but I have seen such a question. I need to look at. Then I will tell you. I may
Okay.
found that question as I have remembered. So I may. Okay. Bacterial vaginosis is a common gynecological condition characterized by a shift of vaginal flora and overgrowth of a particular bacterial species. Most commonly Gardnerella vaginalis. Gardnerella vaginalis is a gram variable facultative anaerobe bacterial vaginosis presents with gray thin malodorous vaginal discharge. Vaginal pH is increased over 4.5. Odor. A fishy odor is detected upon KOH testing. The identification of the clue cell on wet mount preparation is diagnostic as seen in these patients. Metronidazole is the most appropriate pharmacotherapy. Bacterial vaginosis is not considered a sexually transmitted infection, and treatment of asymptomatic sexual partners is not and treatment of asymptomatic sexual partner is not recommended. Okay, so they have told us like treatment of asymptomatic sexual partner is not recommended.
Oh, I think that's what you were trying to say. That or you that's what you were trying to say that the partner is not treated.
Yes,
Okay, yeah, that one I knew. Yeah, the only one that you treat the partner is what's that one?
when there is like symptoms.
No, no, no. You never treat this one. You don't treat the partner. But there is one that you treat the partner. One of those ones.
Trichomonas vaginalis.
Trichomonas. Yeah, because that one is a STI. Yeah. Okay. Mm, next. 82 men comes to physician for follow-up exam. He has a 2 year history of painful tingling sensation in his feet that did not respond to trials of gabapentin and carbamazepine. He has 20-year history of diabetes treated with glyburide. Exam today shows normal muscle strength. Sensation to light touch is decreased to the mid calves bilaterally. Which of the following is the most appropriate alternative pharmacotherapy for this patient? Mm, mm, Trazodone. How was Trazodone again?
Trazodone like ZZZ. Like if there is insomnia there, then maybe there is a mnemonic. I forgot.
Trazodone. Oh, is one of those antidepressants that causes that. Okay, okay. Not that one. I think it's this. this one. I'm not sure.
Um, muscle strength. Okay, okay,
Okay. Where is it? This one. 30. Okay.
okay. Nortriptyline is a nortriptyline, a tricyclic antidepressant, is the best alternative for is the sorry, a nortriptyline, a tricyclic medication, is the best alternative for the patient with diabetic neuropathy that is refractory to gabapentin and carbamazepine. Carbamazepine. Okay. Now, diabetic neuropathy typically develops in patients with and poorly controlled, long-standing and poorly controlled diabetes mellitus. The location of the location of the neuropathy tends to be stocking globe distribution, and typically ascends from feet to more proximal portion of the leg. Symptoms can range from the loss of the sensation to dysesthesia. Early detection is essential, as improved glycemic control can halt or slow the progression of the disease. Testing is testing is completed in ambulatory setting with the use of monofilament with the location of the neuropathy tends to be stocking as globe distribution, gradually ascends from feet to more proximal uh, portions of the leg. Symptoms can range from the loss of the sensation to dysesthesia. Early detection is essential, as improved glycemic control can halt and slow the progression of the disease. Testing is completed in an ambulatory setting with the use of glycemic control can halt or slow the progression of the disease. Testing is completed. Loss of ability to detect one or more of these pressure points should prompt further evaluation and tighter glycemic control. First line is gabapentin, and as it generally well tolerated, but some patient may require additional or alternative medication refractory symptom. In conjunction with the therapy, patients should undergo frequent foot examination to detect any ulcer, or cuts or diabetic foot indication. Okay,
Okay.
you found the trazodone.
Yeah, fast founded on sketchy. This one is not good, a good picture, but yeah, the one that caused priapism, I think it's this one. This one that causes priapism, and it also causes sedation. So it blocks alpha 1 and it causes priapism. And it's an antidepressant. Yeah, it's this one. Does it, can you see
Mm,
it? Oh,
yes,
no, it's too small. Okay.
trazodone. Okay,
Okay.
according to first aid,
Mm-hmm.
there are something like trazodone primarily blocks 5-HT2 and alpha 1 adrenergic and H1 receptor. So it is used primarily for insomnia. A higher dose is needed for antidepressant effect. Adverse effect is sedation, nausea, priapism, postural hypertension. And
Mm-hmm.
think about trazobone, that means due to sedative and male specific adverse effect. Male specific.
Huh?
May,
Makes sense.
okay. So the key point we need to remember, like in here,
Mm-hmm.
like ZZZ, when we sleep in the cartoon we have seen, like ZZZ in the, so it means it is used for insomnia. Okay,
Mm-hmm.
I got it.
40,
Can,
42
can
women.
you give me 2 minutes?
What is, okay. 42 women comes to physician because of recent high blood pressure readings. During the past month, her BP was 150/94, and on two occasions at health fairs. She has history of migraine that have occurred twice weekly during the past 6 months. She has been taking ibuprofen 4 to 6 times weekly for her migraine. She has no other serious illness. Takes no other medication. Pulse is fine. BP is high. Reminder of the exam is fine. In addition to discontinue ibuprofen therapy, administration of which of the following is the most appropriate next step in pharmacotherapy? Hmm. Hmm.
Why alpha blocker?
If not sure. I mean,
He has migraine, so migraine prophylaxis is beta blocker, not alpha blocker. Alpha blocker,
oh,
alpha blocker is given like tamsulosin, and this is for BPH with hypertension, isn't it?
that's true.
And
That's true. I mean,
AC inhibitor is the actually the drug of choice, but as the migraine is highlighted, that's why I am thinking. But the
yeah,
first line drug is AC inhibitor.
it makes sense. I didn't go with AC inhibitor because
A,
he,
but there is AC as well as ARV2. You got it.
yeah, yeah.
So
Okay,
I think that beta blocker should be the
makes
maybe the
sense.
option.
Makes sense. Yep, you're right.
Okay. Migraine is a common indication that presents with recurrent primary headache that are typically severe unilateral throbbing associated with nausea, vomiting, and photophobia and phonophobia. Migraines are postulated to arise from deficient serotonin inhibition of dissenting pain pathways. Through many, though many causes have been proposed for patients with disabling or frequent migraines, prophylactic treatment is recommended. Beta-adrenergic blockers are among Beta-adrenergic blockers are among the commonly used first-line agent for migraine prophylaxis. The mechanism by which they impart migraine prevention is poorly understood and is not believed to be directly related to their effect on blood pressure. Other options for migraine prophylaxis include antidepressant, tricyclic antidepressant, SNRI, and anticonvulsant. Notably, these patients' blood pressure is potentially worsened as a result of renovascular effect. Notably, these patients' blood pressure is not potentially worsened as a result of renovascular effect of the ibuprofen, and beta-adrenergic blocker may be suitable choice to both treat hypertension through beta-adrenergic blockers are otherwise not first-line therapy and prevent migraines in this patient. Okay.
because NSAID cause
NSAID can
constriction, right?
cause
Of the
yeah, afferent arteriolar constriction.
and
Is
ACE inhibitors causes what?
ACE efferent. Sorry, NSAID cause if ACE. Uh, sorry,
I know.
NSAID
Okay,
cause afferent arteriolar constriction, and NSAID cause efferent. Am I saying wrong?
no, you're saying it right. So prostaglandin dilation of afferent. So NSAID cause restriction, constriction of afferents. Now ACE, the actual ACE causes, I think, is
Efferent.
constriction of efferent. So ACE inhibitor causes dilation of efferent. Okay, got it. Got it. Got it. 32. Previously healthy 30 women come to physician because fever. I like those short questions. Because of fever, non-productive cough, and left-sided chest pain for five days. Her symptoms started during a hiking trip with several friends in late August. One of these friends has similar symptoms. Mild diffuse crackles are heard. Which of the following is the most likely causal organism? After hiking, fever, cough, and left-sided chest pain for 5 days.
Hiking, scamper, hiker, fever, non-productive cough, left chest pain, trip, August, crackles. Is it pneumonia type of feature?
Pneumonia type of feature. Um, I
He has
guess
like only crackles, and it is not strep pneumonia, isn't it? Strep pneumonia cause high fever,
high
and
fever.
Borrelia burgdorferi comes with the heart and the like joint pain. Coxsackie can cause aseptic meningitis. Coxsackie can cause pneumonia. It is either influenza or mycoplasma. As it is hiking camper, maybe mycoplasma. Maybe I'm thinking. Coxsackie may be the answer. I
They
don't know.
gave you a clue late August. Remember, I always say like they give you something that doesn't have, like, why are they telling you about August? It must be a clue.
Why late August is related to Coxsackie?
Yeah, I'm thinking. That's why I'm thinking. I don't know. Okay, let's see. Where am I? Oh no, you were right. Well, yeah, yeah.
Is late
Oh,
August is related to? Okay, I am reading.
no, I
Sorry.
sorry, but go ahead.
Like when I think about Coxsackie, I think about aseptic meningitis. Like remember the Coxsackie type A and B in the sketchy, the bird is
Yeah,
ripping up the heart, myocarditis, and he's like the Kakatua, like this type of bird is two birds are in the like in the cell, and they are like ripping off their heart, as far I remember.
yep.
Okay. And it can cause hand foot mouth. This is very common.
Mhm. Oh, that's what I was thinking.
Which one?
The pain from you see that pain that says that pleuritic chest or whatever chest pain
Okay.
unilateral.
This pleuritic chest pain is due to like uh, DCM, like pleurodynia.
Um, is that what do you mean? No, it's not due to the heart. It's like pleuritic. It's like
Okay.
yeah, mhm.
Okay. Uh, Mycoplasma pneumoniae is the most common, sorry, Mycoplasma pneumoniae is most likely causal organism. This patient has a fever and a cough with diffuse crackles on the diffuse crackles on lung examination, which are findings most consistent with pneumonia. A chest X-ray should be obtained to evaluate for the evidence of pulmonary infiltrate. Pneumonia can be caused by viral pathogens such as influenza or severe acute respiratory syndrome, cough 2, or by bacterial pathogen. The most common bacterial organism include strep pneumonia, Haemophilus influenzae, Chlamydophila pneumoniae, Mycoplasma pneumoniae. Infection with strep pneumonia tend to be more severe than infections with Mycoplasma pneumonia. Thus, infection with the latter is sometimes colloquially referred to as walking pneumonia. It can be challenging to definitely identify the causal organism. So patients are typically treated empirically with antibiotics that have activity against the most common organism.
Can you read C and E?
Yes. Influenza virus is a common viral pneumonia during winter months. This patient has developed symptoms in the summer, which would be atypical for influenza infection. Strep pneumonia is a common bacterial cause of pneumonia, but patients tend to present with focal lung findings indicating a lobar pneumonia. They also tend to have more severe symptoms than patients with mycoplasma or pneumonia infection. Okay.
Mild diffuse crackles. Okay. Next. Previously healthy 32 man comes to physician because of 4-month history of constant pain on the outside of his right elbow. On the outside of his right elbow at rest. The pain has not responded to NSAID or wrist splint elbow. He's right-handed. He recently began building an addition to his house and has been lifting heavy supplies. BMI is fine, 5 foot tall. Exam shows severe tenderness of the bony right distal humerus, 1 centimeter proximal to the radial head. Okay. Extension of the right wrist against resistance produces pain at the area of maximal tenderness. Anterior, posterior, and lateral exit of the right elbow show no abnormality. Which of the following is the most appropriate next step
Extension of
to manage?
the against extension of the extension, flexion, extension of the radius of the humerus and 1 centimeter approximate to the radial was the Okay. Okay. A is the right answer. Okay. So use of forearm step. So use of forearm strap is the next most appropriate step in the management of the patient who is likely has lateral epicondylitis. The lateral epicondylitis is the lateral aspect of the distal humerus and is the origin point of many wrist extensor muscle. Thus, the pain in the lateral elbow with wrist extension is commonly seen in tennis elbow. Common mechanisms of injury include Common mechanism of injury include repetitive motions of wrist while under a heavy load, such as what may occur with frequently lifting heavy objects. Patients who are patients who are not conditioned to regularly perform these sort of tasks are at higher risk of injury. The physical examination discloses tenderness over the lateral epicondyle and over the insertion point of the extensor muscles of the wrist. Having the special tests include having the patient hold the heavy object in the affected hand when the arm is raised and the elbow is extended. Mm, okay. Special test having the hold a heavy object in the affected hand while the arm is raised and the elbow is extended with the head pronation. Patients with positive test will experience at the lateral epicondyle with this maneuver. Treatment is initially with activity modification. Treatment is initially with activity modification and a compression sleeve or a counter force bracing apparatus. This type of brace applies pressure distal to the origin of the point of the wrist extensor and helps relieve some of the pressure on these area during wrist movement. Okay.
Okay. 37 men comes to physician because intermittent chest pain over the past 2 days. 4 days ago, he had a sore throat, headache, and malaise. 2 days ago, he developed fever and sharp stabbing pain in the right lateral chest. The pain resolved spontaneously after 1 hour, but has recurred 6 times since then. There is no pain with exertion. He appears well, temperature fine, pulse fine, BP fine, lungs are clear, cardiac exam shows it's fine. Lab studies, hematocrit, I believe it's fine. Leukocyte count fine, platelet fine. CK, I believe it's high. Okay. X-ray of the chest and ECG showed no abnormality. I hate when they do that. What is the diagnosis? Let me look at the hematocrit. Is a man. Hematocrit, it's fine. Wait, CK is high, right?
CK is CK
Yeah.
is high.
Chest pain, sore throat, blah, blah, blah. Headache. Mm, sharp stabbing pain.
Sharp stabbing pain on the lateral chest.
Mm, mm, hmm.
It is not pericarditis, isn't it?
I don't think so. The CK high thing, it's a key, but
And it is not SLA because like platelet count is low. Usually thrombocytopenia happens in the SLA.
so why
Then,
would they be?
it may be pleurodynia.
Fluorodenia is the plura, but why would the CK be high?
Pleurodynia. CKD is such very high or normally high.
No, it's high. It's really
Not
like the normal
normal
is
CK is,
normal CK is 25 to 90.
so it is bit high.
Um,
It is not
Fluorodenia.
infection. Empyema is a serious infection.
And
Like
fluorodenia is what? Is infection of the flora?
infection, maybe It is not the
Yeah,
infection only. There may be pain syndrome in pleurodynia. Maybe. I don't know actual answer.
I don't know. I feel like it's between the. I don't know. I
You give,
wanted to say lupus.
sorry.
I wanted to say lupus, but you say lupus doesn't make
No, no,
sense.
lupus can happen. Usually in lupus, I found the thrombocytopenia, but lupus comes with multiple disorder. Lupus can come with pleuritis. Yes, you are right. It may be the answer.
Let's see.
Maybe.
Where is it? Nope, you were right.
Okay.
Oh, it's the thing that we just saw the Coxsackie. Yeah.
That thing happens usually when you don't tackle any question. The what we have seen is just a visual thing. Okay. The devil's disease, isn't it?
Mm-hmm.
Okay. Pleurodynia, also known as Bornholm disease, uh, is an acute viral illness caused by Coxsackie bee, among other virus. Headache. It presents with fever, headache, and characteristics paroxysms and paroxysmal spasms of the muscles of the chest wall with pleuritic chest when Coxsackie virus is an RNA enterovirus. Coxsackie virus is an RNA enterovirus that is transmitted via oral secretion or feces. Pleurodynia tends to occur in the epidemic outbreak. Pleurodynia tends to occur in the epidemic outbreak during the summer months. Patients may present with leukocytosis, increased serum concentration of the creatine kinase caused by muscle inflammation. The disease is usually self-limiting and resolves over several days to weeks. So it
So
is a
it's the
self-limiting disease.
it's not the pleura that's inflamed, it's the muscles of the chest that are inflamed. But because it's kind of like a pleuritic pain, that's what they call it pleurodynia. Okay,
So
got it.
as the muscles of the chest is involved, that's why CK is high.
That's what it is.
There is some sort of muscle breakdown.
Yeah, the name is confusing because it looks like it's like a plural disease.
Okay.
Okay, next. That was good to know. 37 women comes to physician because Freeman history of generalized fatigue. Freeman. She has noted decreased energy level, which is most pronounced at the end of the day. She has 3 year history of abdominal bloating and intermittent diarrhea, especially after eating pasta. Her appetite has not changed. She has had no weight loss. Menses 28-day interval with life flow for 2 days. So BMI is normal. She's 5 foot tall. Pulse normal, BP normal, exam shows moderately pale oral mucosa, abdomen is distended and tympanic, there is no tenderness or organomegaly, rectal exam is fine, test toracol blood is negative, hematocrit, I believe is low, not sure, mucosal count is fine, and platelet count, I believe is high. Which of the following is likely to confirm the underlying cause of the symptoms? Let me see the hematocrit. 30, which is female is low. Fatigue, abdominal bloating and diarrhea.
After taking fatty food like pasta, abdominal
Mhm.
bloating and diarrhea,
Mhm. What is chilling text? I forgot.
Schilling test for vitamin B12 and B9, like vitamin.
It's
Maybe
not
due to
that
pernicious anemia. Maybe
pernicious anemia. Okay, then the mean
it
turn
is
is
not
not
that.
killing them.
No, no, I don't think
Colonoscopy
so.
would be
Colonoscopy,
transaminase is it the celiac or the gluten?
celiac is the gluten.
Oh, celiac is the same thing. Never mind.
I think that it is gluten enteropathy or celiac disease, isn't it? It is not
Yes.
like pancreatitis. Pancreatitis is a serious pain, like, and pain radiates to the back. Mm,
Yeah, probably. Yeah, probably that.
and as they have told us, the confirmatory test like anti-tissue transglutamase, anti-gliadin antibody, and there is another tissue transglutamase, anti-gliadin. There is another antibody, maybe
Anti
gliadin,
endometrial.
endomysial. Yes.
Okay, ready? Very well. Yeah, we're right.
Okay. So celiac disease. Celiac disease is a gluten sensitive. Celiac disease is a gluten sensitive enteropathy that is mediated through immune tolerance of the protein gliadin, commonly found in wheat products such as pasta. These results in infiltration of the proximal small bowel, which leads to characteristic intraepithelial lymphocytosis, villus atrophy, crypt hyperplasia, malabsorption of the substance in the proximal small bowel ensures, which presents symptomatically as chronic diarrhea, steatorrhea, and nutritional deficiencies. Patients with celiac disease may develop iron deficiency anemia, which are present on lab studies with decreased hematocrit and microcytosis. The diagnosis of the celiac disease can be confirmed by detection of the anti-tissue transglutamase antibody or by small bowel biopsy demonstrating villus atrophy along with intraepithelial lymphocytosis. Crypt hyperplasia treatment includes avoidance of the gluten containing foods and reversal of any acquired nutritional deficiencies. Okay.
Here we D as in dog, as in donkey.
Okay. CT scan of the CT scan of the pancreas is useful for the diagnosis of the pancreatitis or pancreatic cancer. While pancreatitis may lead to malabsorption, diarrhea, and bloating, these patients lack suggestive symptoms such as abdominal pain or steatorrhea. Okay.
Next. 11 boy brought to the camp infirmary by his camp cabin mates 1 hour after collapsing. The boys had been playing a game that involved standing, breathing deeply, rapidly for 1 minute, and then expiring against a closed mouth. Stupid. The patient collapsed and struck his head on the edge of the bed. He did not open his eyes or move for several minutes, but is now alert and fully oriented. There is 1 centimeter ecchymosis on the occipital scalp. His pupils react to light. Reflexes are symmetric. Gait and muscle strength are normal. Which of the following is the cause of the loss of consciousness? Hmm.
Is it epidural hematoma?
Mm, you want me to check? Ready?
Okay, okay.
Ready?
I have given my answer.
Okay.
Whatever it happens.
Whatever happens. No, it's not.
Okay, we both are wrong.
Wrong, so wrong.
We haven't think on that way. Okay, no problem. Cerebral hypoperfusion. The patient likely experienced a syncopal. The patient likely experienced a syncopal episode secondary to cerebral hypoperfusion. The serum, the serum pH and PCO2, the serum pH and PCO2 are the primary regulator of the cerebral blood flow. Acute acute hypocapnia, which can be caused by breathing deeply and rapidly, cause a respiratory alkalosis that results in cerebral vasoconstriction and decreased cerebral blood flow. In addition, forced expiration against a closed glot is the Valsalva maneuver, rapidly increases intrathoracic pressure with a corresponding decrease in the venous return, preload, and cardiac output, resulting in abrupt drop in the mean arterial pressure. The combination of these two factors can result in significantly reduced cerebral blood flow and consequent syncope. In the absence of an underlying pathologic process, resumption of normal respiratory drive and a supine position resumption of normal respiratory drive and a supine position will quickly correct the perfusion deficit, resulting in restoration of consciousness. Okay.
Okay. 27 men comes to physician because 1 week history of yellow eyes and dark urine. He has a history of IV drug use. Lab study 6 months ago showed positive for Hep A antibody assay and negative for Hep B surface antigen assay and positive Hep B surface antibody. Exam today shows jaundice and hepatomegaly. Lab studies are consistent with hepatitis. Which of the following is the cause of his hepatitis? Ready?
Yes, jaundice and mm, yes. Okay. It is hepatitis C infection. Hepatitis C infection is most likely cause of this patient's hepatitis. Hepatitis C is transmitted through exposure of the blood and can be acquired through IV drug use, and sexual intercourse, although less common. And before the advent of universal screening from blood transfusion, HCV is an RNA virus that establish residence in hepatocytes. Acute infection causes an increase in liver associated enzyme and occasionally jaundice. The acute phase is self-limited and maybe lead to development of chronic infection. In some patients, chronic infection can lead to cirrhosis. The diagnosis should be suspected in individuals with lab and physical examination evidence of the hepatitis and a history of IV drug use. The diagnosis is made by using a two-step process. The HCV antibody tested first. If positive, HCV antibody is tested first. If positive, HCV viral load should be measured. Patients with HCV infection will have a, a patient with HCV infection will have both positive antibody and a high viral load. Fortunately, most instances of the HCV infection are now curable with the use of newer medication like ladipasvir or sofosbuvir for 8 to 24 weeks.
Okay, next. 32 women is referred to the physician because of anemia noted on routine testing prior to blood donation. She felt well until recently when she began to experience decreased exercise tolerance. She has regular menstrual periods with no abnormal bleeding. Exam shows no abnormalities. Test for occult blood is negative. Lab hematocrit, I believe that's low. And MCV, I believe is low too. Leukocyte count is not fine. Blood smear is show which of the following is the most appropriate initial step. Hmm. Hmm.
It does not look like, what can I say? It does not look like iron deficiency in me, isn't it?
Doesn't, but it's the only thing that makes sense.
Why is that?
Well, no, I mean something else can cause low MCV, right?
Low MCV has four causes. Microcytic hypochromic
Let's see.
anemia
I
is
don't know.
iron deficiency anemia, thalassemia, sideroblastic anemia, and anemia of chronic disease.
Sideroblastic, okay, thalassemia, serum iron. So you say it doesn't look like iron,
I
so
don't
it
think
might.
so. And the
Yeah,
if it is iron, she has regular menstrual period and with no abnormal bleeding.
yeah,
How it is iron?
yeah. So it's probably not iron. It's probably the thalassemia.
So I think that hemoglobin electrophoresis should be the answer.
Okay, let's check.
No, you are right.
No, no, no. I went with the with hemoglobin electrophoresis too.
But we are right, not on the.
Yeah, it was iron.
It was iron. Then how?
That's
Is
weird.
is this the pencil cells?
No,
Okay,
I think that
yes.
yeah, I think that even if it's not iron, you have to first check the iron always. I think that's the issue here. But
Okay.
okay, read it.
Okay, I'm reading the explanation. Measurement of serum iron and ferritin concentration should be performed in patients with microcytic anemia. The differential diagnosis of the microcytic anemia includes alpha and beta thalassemia, anemia of chronic disease, sideroblastic anemia, and iron deficiency anemia, among other several rare causes in young female who are actively menstruating. Iron deficiency anemia should be suspected. By assessing the diagnosis is made by assessing the serum concentration of the ferritin, the storage of iron, the storage form of iron, and the serum iron concentration, both of which are will be decreased. Iron is required in the synthesis of the heme, which is necessary component of the hemoglobin molecule, and thus of erythrocyte. To its function to shuttle oxygen and to and from peripheral tissue. It is thought that erythrocytes are microcytic as a result of continuing erythrocyte division in order to reach an adequate hemoglobin concentration. Because hemoglobin stores are inadequate, cell division continues beyond what would be normally occur and causes the cells to be smaller than normal. Treatment for patient include oral iron supplementation if severe patient may require IV infusion. Okay, why it is not hemoglobin electrophoresis? Can be used to diagnose sickle cell and alpha and beta thalassemia and variety of the hemoglobinopathies. Patients with iron deficiency anemia with a normal electrophoresis. Additionally, this patient has recently become asymptomatic, and hemoglobinopathies are inherited condition, uh, often present in infancy. Okay, so what is the take home for
It's
this patient?
basically if it's a woman that's still seeing this still having her menses and you see my microcytic anemia, you always first check the iron. It doesn't matter if the menses are fine, she doesn't have any risk factors, but you always it's just easier. It's the easier first step. Just check the iron instead of doing hemoglobin electrode and all that. Is the easier first step. Now,
Okay.
if you there was even a question where it was like I don't remember. I think it was
Like
on you word.
uh, iron first.
Yeah, and they were saying that give the person iron first. That you didn't even check. You just started giving the iron first. Then after a few months, if they still have like the anemia, then that's when you go and check for all these other things. So yeah, let's check iron.
Okay.
Previously healthy 37-year-old woman who works as a prison guard comes to physician because 2 month history of low-grade figure fatigue and cough productive of scanty white sputum that is occasionally broad streak. She has had no shortness of breath, and she has smoked cigarettes for 20 years and drinks like four alcoholic. She drinks a lot. Temperature is fine. Temperature is fine. Pulse is fine. Respiration fine. BP low. Exam shows bronchi that clear with coughing. No results are heard. Exam shows no there are normality. Labs hemoglobin. I believe that's more. That's low. Sorry. AST and ALT, I believe those are high. Alphos, bilirubin is high. Alphos, where is alphos? Is normal. X-ray of the chest shows a normal cardiac silhouette and right upper lung field infiltrates. There is no pleural effusion. Oh, jeez. Which of the following is the cause of the cough? Right upper lung infiltrate. Hmm.
There is no rapid weight loss. Is there?
No.
But 2 months history of low grade fever. In the
Mm,
jail or in the prison like TB,
yeah,
there is
you,
propensity.
you, yeah, you would think TB, but why upper lung infiltrate inoculate? It just doesn't like you will go with TB, but it just doesn't.
Why upper lung infiltrate? You are talking this.
And then AC, and then okay, I guess TB, but it just doesn't.
TB
Why
can
upper?
come with the blood streak sputum.
I
Sometimes
know, but the bronchi that clears with coughing.
bronchi that
Doesn't
clears
that sound like
bronchitis.
kind of okay? Let's not. Maybe let's not think about it that much. Let's go with TV. I
Chronic
feel like
bronch.
it's
Sorry.
feel like it's just too much of a like it's not like it's too much of a easy like a giveaway. Okay, that's fine. Let's just go with it. Let's not
No.
overthink it. Ready?
Yes.
Yeah, I guess let's not overthink. So
Yes, because
let's not overthink.
yes, because overthink sometimes kills our answer.
Yeah.
Okay. Mm, this patient's presentation with signs and symptoms of fever, fatigue, and productive cough and upper lung fill infiltrate is concerning for pulmonary tuberculosis. Primary tuberculosis result from an initial exposure to Mycobacterium tuberculosis leading to development of hilar lymphadenopathy and pulmonary calcified granuloma known as GON complex. Secondary reactivation tuberculosis typically results in apical pulmonary infiltrate fibrocaseous with the fibrocaseous cavitary lesions. It classically presents with fever, night sweat, weight loss, and hemoptysis. Patients may also develop anemia of chronic disease. Chest X-ray may demonstrate apical opacities or cavitary lesions. The diagnosis may be confirmed with culture and samples obtained from sputum or bronchoalveolar lavage. Purified protein derivatives testing and serum interferon gamma release assay are important screening methods for asymptomatic patients but are not adequate for confirming the diagnosis. Patients with alcohol use disorder and patients experiencing homelessness and those from endemic areas, Africa, uh, South America, and those living or working in those close quarters such as nursing care facilities or prisons are more likely to contract tuberculosis. Reactivation tuberculosis requires combination antimicrobial treatment including rifampin, isoniazid, pyrazinamide, and ethambutol, although with initial respiratory isolation. Okay.
Okay, got it. 40. Otherwise healthy 9-year-old girl brought to the physician by her mom because she noticed a lump in her daughter's left breast 10 days ago. The mother has a history of breast cancer. Patient is 70 percentile for height and 40 for weight. Breast development is standard stage 2. Pubic development is 1. There is no axillary lymphadenopathy. Exam shows 2 centimeters slightly. That's mass just beneath the left areola. The mass is tender and slightly granular. There is no redness. The right nipple is slightly tender, but otherwise it's normal. Okay, which of the following is the next step? Management.
She just mm, there is no menstruation. Mm,
Mm, slightly just beneath the
I think that
line.
it is normal, isn't it?
Okay, so if it's normal, then what do you do? Just follow up.
Maybe. Are you thinking anything else? Like
Yeah, I mean, no. I
there, the
mean,
mass is tender and slightly granular, as she
I
is like in puberty.
mm-hmm,
So
probably.
in
Okay,
puberty, this may present probably.
okay, let's check. Yep, you're right.
Okay, follow-up examination in six follow-up examination in 6 months is appropriate for this young girl who has who has just begun thelarchy, breast development. Puberty in girls typically follows a predictable course of thelarchy to puberty, pubic hair to a growth spurt, and finally menarche. Mild unilateral or bilateral breast swelling can be normal in early puberty because of increased production of the estrogen and the growth of the mammary tissue. Thus this patient's mother can be reassured that is likely a normal finding of the beginning of the puberty rather than a signs of malignancy. However, the patient should be examined again in the 6 months to ensure that no concerning features such as hardening of the mass or lymphadenopathy have developed.
Check C.
Yes, ultrasonography directed biopsy of the mass is not necessary at this time, given that this patient's breast mass is consistent with a normal variant of thelarchy and can be simply be monitored. Ultrasound-directed biopsy can be appropriate if there was suspicious breast mass in order to obtain a definitive pathologic diagnosis. Okay.
Okay. Yeah. Next. Over the past 4 months, 66 women has had progressive shortness of breath on exertion. For 2 weeks, she has had two piloorthopnia and paroxysmal nocturnal dyspnea not associated with neck. Wait. For 2 weeks, she has had two piloorthopnia and PND not associated with neck or chest or armpit. Okay. She has a history of untreated borderline hypertension. Her pulse is fine, respiration fine, BP is high. Exam shows a 3 centimeter jugular venous distension. Bilateral respiratory crackers are heard, most prominent at both lung bases. There is a laterally displaced apical impulse and S3 gallop without murmur. There is mild pitting edema bilaterally. What is the most appropriate next step in diagnosis? Sorry.
Can we take a break?
Oh, okay. Yeah.
We can solve it after the